contrast experiences, because I think what I want to tell about is a project that calls Stimul and also Stimulans. I'll begin with immersion sessions that you can go through as a patient for for example, 2 days and a night, as we started it in West Flanders. I want to tell about this. And I want to tell also about the role of contrast experiences in that experience, being in such an immersion session, and what is doing this kind of experience with your formation process, to say it with the words of Guus before. By saying now, what is a contrast experience? Maybe it's the example that I told from yoga. Witnessing such kind of conversation between a nurse, it's really distressing you. And that distressing experience is maybe a core element of what a contrast experience does and is. And by telling about that kind of experiential learning, I tried also a bit through the lines to tell something about why is that kind of experiential learning so important in nursing and in formation of healthcare professionals, and what is it, or what can it be, and maybe also tell something about how is it to be in such a caring formation process. I have introduced already a bit what I want to say with Joke's story, or a part of her story, but I want to introduce also something that I read and what was inspiring for me. Then I want to go to the ultimate goal of experiential learning in ethics, and that's, I think, cultivating character of care. I want to give the example of the immersion sessions, being a patient for 2 days and a night, a simulant patient. I want to give that example. And then I want to go into the what is the bodily, I think the very bodily impact of that kind of experiential learning, and how does it cultivate that moral character of care. You can read also this in the article. I will also give the article afterwards. I want to give also, after the story of Joke, or one part of the story, I want to focus on a story that really was also very moving for me. That is this book, When Breath Becomes Air. In this book, a neurosurgeon, Paul Kalaniti, he died from lung cancer on the age of 36. He writes in his book, he writes that book from his sickbed, and he writes about his formation as a neurosurgeon, but also about his experiences as a cancer patient, and what this patient, being a patient, does with him as a doctor. And at one point, he writes about a moment that he had a clash with his colleague, but not as a colleague, but as patient, meeting his colleague, who is his doctor at that moment. And the point is that he is on intensive care, and he asked to his colleague, can I get that kind of medication? It's his medication, he is used to it. It's about pain medication. And that doctor says to him, his colleague, I don't give you that because it's not good for you to have it now. And he is astonished about that reaction of this doctor. It's his colleague, Brad, his colleague. Hello, I'm your colleague. Yeah, but at that moment, he realizes that he is not a colleague, but a patient. And then he writes that down. I thought back to med school, when a patient has told me that she always wore her most expensive socks to the doctor's office, so that when she was in a patient's gown and shoeless, the doctor would see the socks and know she was a person of substance to be treated with respect. There's a problem. I was wearing hospital issue socks, which I had been stealing for years. I think this passage can learn us something about cultivating moral character of care. The words of the patient to Dr. Kalanitis stick with him, but they remained maybe a bit abstract, just till that moment. They become now vividly. They gain, let's say, if you know that word, performative power, because he is now recount these words in the shoes and maybe in the socks of that patient. And now he really understands the meaning of these words, because he has the experience himself of being treated paternistically, childishly, as if he is now, even as doctor, he is now a patient, and there is a doctor just who's saying what he has to do. And in that experience, these words of this patient, the earlier patient, is becoming now very sharp to him. I think that by this experience, he will be, or would be, if he could have had the chance, could be another doctor after this experience with these words of this patient. I think this also, just like the example of Joke, is an example of what we call a negative contrast experience. And one of the first who talked about that, who has written about that, is this famous theologian, Edward Schillebeeckx. Edward Schillebeeckx was already in the year 60 writing about this very human experiences. And he describes a negative contrast experience. It's undergoing or witnessing something that let you shut out. This cannot be allowed. This has to stop. This cannot continue. This is not right. And it is a contrast experience because you feel into your body the contrast between what is good and what is not good at all, what is evil, also in a moral sense of the word. But you feel it in the flesh, in the body. That's the power of the contrast experience. And that is not already ethics, Edward Schillebeeckx says. It's the beginning of the ethics, because you cannot otherwise do than reflect on that experience. It's so impactful that you cannot do otherwise than reflect on it, then do something with it. It also bringing you into action because it let you shut out, this has to stop. And everything in your body is, and it's precisely, I think, if we go to the experience of Joke, what Joke experienced, she is witnessing something that she, and almost with all her postures said, no, this cannot be. And maybe that's also the experience of Paul Kalaniti when he is experiencing his sock issue conversation with Brad, his former colleague. And we saw that this was a lot, this contrast experience, negative contrast experience, is also what a lot of people who were into our care ethics lab in this isn't already existing anymore, but this was our first care ethics lab in Moorseel in West Flanders, where, if you can see it in the pictures, people could have the experience of being a patient for 2 days and a half. They were the first groups were healthcare professionals working in a nursing home. And they came to this house for being a patient for 2 days and a night. And they were cared for by students nursing or nursing assistants, students nursing assistants. And they were experiencing for 2 days and a half how it is to be treated as being in a nursing home or on a geriatric ward. And a lot of the experiences, how good they also were mentioned and intentioned by the simulant caregivers, a lot of the experiences of the people who were in the lab for 2 days and a night were negative contrast experiences. And they still remember, some of them experienced this, how long? More than 10 years ago, and they still remember the 2 days and a night, and very detailed also some things that they experienced there, because it were really negative contrast experiences that they felt into their body. So I want to tell about this and what it does with the cultivating character of care and, character for care. But before I'm jumping to what happening to people, the contrast experience of people in the immersion lab, I want to tell something about what is that character for care. And I think already Gus told a lot of it, but I want to focus on some points in also some things that Gus already mentioned. I refer to Stan van Hooft. Stan van Hooft is a nursing philosopher here, and also to the work of a care ethicist as Joan Tronto. Joan Tronto's work as, I think, one of the most influential thinkers about relational care, also on a political level. And Stan van Hooft says about character for care, let's go to the saying of a patient about a nurse, and the saying is, he is a good one, that's a good nurse, or she's a good one, that's a good nurse. What do people refer to when they use that words? And then he said, that's referring to the integration of their action, what they do, with emotions, with motivations, and with knowledge. Let's say it's the right action with the right emotions, the right motivations, and the right knowledge. That's caring as something in the character of the nurse is central to nursing, he says. And in the first place, so this kind of caring involves knowledge. And I think also Gus refers to a lot to that. What kind of knowledge and how can we get that knowledge? And it's, of course, very relational. That's what Gus already emphasized. And indeed, Stan van Hooft and Joan Tronto says about that kind of knowledge. In the first place, it's not only theoretical knowledge, which is very important, of course, but it is, in the first place, knowledge about what is at stake for the other. What is at stake for the one who is the patient. There it begins. I refer to Joke's experience, and what's lacking here in the first place is the knowing of the nurse here. She does know what it is for the patient to be in such a vulnerable situation. She is looking to the patient from her program. And that's a different program in the evening than in the morning. She is not starting from the knowledge about what it has to be for a patient to be in this shameful, also undignified situation. And that's where it begins. It begins, I think, in the character for care, it begins with knowing what is at stake for the other. And Tronto, First Van Hoof says, this knowledge stems from a more or less articulate grasp of the value and significance of what it is to be a person who is suffering from malady or mental distress, of pain and suffering. And Tronto says it's an understanding what vulnerability means. And I think this kind of knowledge asks a change of perspective, as already mentioned with the nurse of yoga. It means that you can make the change of perspective not from you to the patient, but from the patient to you. That's the change of perspective that we need for having this kind of knowledge. A second element, I think, is the action also involves motivations. And I think that the kind of knowledge that I mentioned before is the kind of knowledge that also bring you into action. When you see what is at stake for the other, for the patient, you come into action. You cannot do otherwise than take responsibility for it. You come into action. That's the responsibility. You feel appealed. At least the nurse, also in the experience of yoga, when the patient was weeping, at that moment, she was appealed. She said, oh, okay. And at that moment, something shifted. That moment was taking the other perspective, the perspective of the patient. And then she was, I think, coming into the motivation of doing something to that shameful and undignified situation of the patient. And I think that that's the right motivation and responsibility here, and that's where Tronto refers to, is a moral quality. There is no other way that the need will be met except by our meeting it. I think that kind of motivation is a very important one. I will tell further also about it. I have a son who is now 10, who has autism and has an intellectual disability. And in the week, he is in a care organization from Monday to Friday. And he was 7 when we brought him to that care institution for the first time. And I really remember one of the healthcare professionals there who said in the first week, but also in the second, the third, the fourth, and the 5th week, when he brought him the Monday to his care institution, he said, you know, you can always call. Every evening you may call. I have a child myself, and I cannot imagine what it must be for you to take your child to here at such a young age and being here for whole the week. And I think I felt the emotion, the motivation of that. She was motivated by the knowledge that she cannot know, as she said it explicit. She never can know what it must mean for us. And by that knowing, which is not knowing, is precisely the motivation for having this caring attitude, for saying to us, it never mind, you will never be the, how do you call that, the annoying elders who always, you will never annoy us. You can ring whenever you want. I think that's the link between knowledge and also motivation. And the third element in that moral character for care is emotion, of course. And I think the emotional in the experience of yoga, you see her emotion about the distress, about what happens there, but she is emotioned about the non-emotion of the nurse, the first non-emotion of the nurse. There was no emotion at all. It was a very, and yeah, then it changed when the patient was weeping, and then she changed, and then she felt emotion. And I think that's the emotion that is accompanying the right motivation and the right knowledge. that has also to be right. We, as also Stan van Hoof says, virtuous nurses need not to be gushing in their emotional responses, but at least there is emotional involvement. And that's minimum. We have a very famous psychiatrist in Belgium, Dirk de Wachter, who is also writing books about Levinas, the French philosopher. And he is also in a very, he is a cancer period now. He's a cancer patient. And in one of his, I think, lectures that is also recorded, he is telling about a moment that he is in he has a delirium from the morphine he gets after his operation. And he is very, how do you say that, in delirium. And it's happening in the night in the hospital. And he tells that a nurse is coming into his room, very quiet, friendly, saying his name. And only that is making him a lot easier, more, and she's doing what a nurse has to do. And he says afterwards, I could hug her. And I said it to her, oh, nurse, I should hug you, but it was Corona. And she said, sorry. But also there, she stayed very quiet and friendly and said, so no, that's not possible. But that's also the emotional reaction, being quiet, friendly, although it's chaotic. Maybe you're also in a panic, but also this is part of the character for care that we need in nursing. So these three elements. And how can we cultivate that kind of character of care with the emotions, the right emotions, the knowledge, and the motivations? Well, I think that it's not just a matter of course, introducing norms and values. We will not, as also Gus mentioned, we will not bring people into that character of care just by telling to them about the value of values or the norms that we have to respect. It's also something to do with, I think, experiencing and reflecting on your own experiences and experiencing things, reflect on experiences also about situations where you are a nurse, you come into a very uneasy situation, and the reflecting afterwards and taking also the perspective of other involved. In the first place, the patient. And for me, that's ethics. That's why I present here my spiritual father, Roger Burggraaf, also a Rogerio, who always says ethics is in the first place about experiencing, that's Levinas, of course, experiencing uneasiness. He says in French, with the French philosopher Levinas, le mal à l'aise. There ethics starts. You don't feel well. Something is not right. You have to do something about it. It's like scruples, you know, that having scruples. I don't know if this is mentioning something, but that's a scruple is you are very, I don't know what to do. I will ask it. You are very eager to handle, to jump into the action. You reflecting, and scruple is also in Latin. Scrupulus is a very small thing, like a little thing in your shoes when you're going for a walk, and then you have to stop your walk because that little thing is really aching, and you have to put that away. And Roger always says that's ethics. You have to stop. You have to de-routinize. You have to hold on and do that thing, reflect about it, and then you can further. And I think that's also what ethics has to be. And maybe that's an important element in cultivating character for care. And that's also, he mentioned also Dietmar Niet here, which is a theologian who already in the 60s wrote about also the normative ethics of the church. He says, ethics cannot possibly limit itself to normative statements. Ethics must primarily focus on sharpening reflection on experience. Through reflection and confrontation alone, experience is brought to authentic because lived through insights. Ethics, therefore, cannot but be a narrative ethics, an ethics that brings experiences to story. That's the reflection. It is also the task of ethics to create favorable conditions for the unfolding of the critical capacity for experience. And I think that's maybe a bit theoretical, but that was our feeling we also had when we started with Stibu, the 2-day immersion sessions, because we felt that the experience of that Joka has now as a real patient, these are very useful, but we can, I hope it's not ethical to ask from people to first being a patient before becoming nurse, but being a simulant nurse, a simulant patient as a nurse or a student. That was maybe the experience that we thought could be very useful and learningful. And that's why we start our 2-day immersion sessions, being a patient. And we had, as you can see here, on some pictures, one picture is not from Stibu, but it's what. We had the opportunity to have a house with, I think, 6 rooms and 2 rooms for 2 patients, simulant patients. And in that house, it was, let's say, a ward, a geriatric ward, or a ward in a nursing home in small. And we had everything they have there. Also a hoist, how do you call that kind of bath? And we have all possible, let's say, things for hygienic care, toilet care, food care also. You could have the experience of being washed in a high-low bathtub, being helped on the toilet with a hoist, after you have called for that purpose and have waited till the nurse is coming, being helped with a meal and tasting thickened food if you stepped in the shoes of a patient with swallowing problems, wearing incontinence bath and try to use it. I don't think many of them succeeded in really use them because it's so overwhelming that you don't even only have them. Wearing them is enough, is already exposure enough, let's say. Sleeping in a bed with sponges and experiencing restraints when you are a person with dementia who is wandering. Being deprived of autonomy as you are in your wheelchair watching the news in the living room and they bring you back to your room because it's bedtime in the middle of the news without asking anything because the shift is ending for them and you have to go to your room. Being deprived of privacy as different caregivers jump into the room while you are washed by one of them. One of our colleagues was trying to be a patient who had to be helped on the toilet with a hoist, naked. And he is director of a nursing home. And he was being almost on the toilet, and then something happened with the hoist. And the student who was trying to do something about it couldn't do it, and she asked another student, and then I don't know, the mentor of the education, and then Anne was also coming there, and he said, I was there naked, and there were 4 people there, and then I realized that I am, as head of the nursing home, also always knocking on the door, but always said, oh, yes. And then you come into entering a room where there is an older person being washed also intimately, and then you don't look at it and you think it's all right because, but now I realize how painfully that privacy is in such moments. So you see, that is what happening in the 2-day immersion sessions in Stimul. And all participants talk about impressive corporeal experiences they have had in Stimul. The most of these experiences were negative, although the care was was intended as good care. We gave every simulant student, simulant caregiver, the task: do it as well as you can, as good as you can. For example, the experience of how long it takes when you don't know what is going to happen and you are waiting for, I don't know, how tired you get from also that, from sitting in a wheelchair, and how painful it can be, how stiff you come, for example, how shameful it is to spill food on your clothes, how distasteful food is when they spoon you the meal on their tempo. How humiliated it is when others move you without saying, for example, that watching news incident. How small they feel when you lose autonomy and privacy, and so on. That were the most, let's say, negative contrast experiences. For example, one person, so a lot of persons had bad experiences with hygienic care. They were cold, the soap wasn't rinsed properly, so they felt filthy, or the caregivers were with thu and talked above their heads. Also, the food care was very impressive. Sometimes when one is fed by someone else, the food is too hot, the spoonfuls are too big, the pace is too fast. Participants felt as if people were staring at them, and they were embarrassed to sit waiting to receive their food with their mouths open. The pain they felt due to loss of independence may be associated with a feeling of powerlessness and insecurity. And one said, during the nights, for example, I got thirsty and I could not reach my drink. You cannot fathom what it means to be dependent on others for everything, not to be able to reach it yourself, to lie there thinking, when is someone going to show up, or should I call? As I already also mentioned, not knowing what is going to happen next, that was painful to some of them, and sometimes fearful sensation also when receiving care. For instance, having your wheelchair pulled back without knowing who is pulling on your wheelchair and why. Someone said, I felt let down as a person, as I thought I wasn't a person, but an object to be washed during a wash hygienic care, and so on. All negative contrast experiences. So the physical experiences are inescapable. You are feeling them into your body. They are inescapable. And they bring feelings of shame, humiliation, fear. These feelings qualify the perceived contrasts, and that's why I think it are real contrast experiences, between the unacceptability of what happens and what could be acceptable under other circumstances, or even the same circumstances. And that's really let's say, a shock moment that brings people into a reflection mood. For example, one person said, I thought, do we treat our people like this as well? It should be different. It's almost Schellebix himself about the meaning of contrast. It should be different. It must stop. It's all done with the best intentions, but it is a confronting experience. It has to change. Another person said, I always have at the back of my head what has been done to me. When once back in the own nursing home, for example, I will be extra careful when covering them during washing times. I will use a towel to cover them. I feel so cold. It feels so cold lying there. I only had to undergo it once, but imagine lying there every day. And we see that people started to think about this. I had this experience, I will do never this again. or I will be more attentive when I do this. But you had also some participants who had these experiences, their own experiences, and said, I know that I never know what it is for that patient or for this person in a nursing home. So I have to ask it, or I have to feel it, or I have to go into that relationship to try to know what is at stake for that other person. And I think these are the most useful. And I here come to what does it do with the cultivation of character? What is the bodily impact of all this, of this kind of experiential learning in cultivating character of care? It does something with your knowledge. It does do something with your knowledge. A lot of people who were in Stimul said afterwards, I thought I knew it because I have these experiences as healthcare professional for years. And now I had the experience that brings me out of that knowledge. I thought I knew it, but I will never knew it. So I have to ask it, for example. Being with your own body into that situation of vulnerability is bringing another knowledge. And I think it is, in the best cases, an impulse for taking the perception of the other, for taking the perspective of the other into your knowledge. And maybe I think I make here a little reference to Emmanuel Levinas, the French philosopher, who says, I think that this knowledge leads to what he is calling meeting the other person as mystery. It's Joke is mentioning in her video to that experience, I told about it, that it's the experience also of being treated as a problem, something that is troubling me because it brings me out of my routine. That's the person as a problem. And what Levinas asked from us, that's the real ethical meeting the other, is meeting the other as other, is meeting the other as mystery. And I think that the knowledge that you take with you after immersion session in Stimul is a knowledge precisely that you never know it, so that you have to meet the other person, as mystery. I never know it. So I have to go into an adventure with the other. I have to seek what it is at stake for the other because I don't know it. And that's meeting the mystery of the other. Not taking your starts of knowing the diagnosis, knowing what medication is needing, but that's also the same with Kalaniti. His colleague is not meeting him as another person, but is meeting him as a problem. And he felt that. And that's maybe what Levinas, when I was in earlier times with my young child at that moment, who has autism, in some places where they don't know him, because he can do things that we don't understand, we said in earlier times, he has autism. And what happened then is that people said, oh yeah, we see it now. Yeah, okay, we understand it. It's autism. Or sometimes he is making eye contact with me. That's strange for an autist, isn't it? You see that they all start from seeing him in his autism, meeting him not as a person of that age, 5 years, a boy of 5 years with autism. They only see that autism. And then for me, I think, I don't know what is precisely in his doing, what is precisely from that autism, or what is typical for him or typical for his character. He's also the character of my wife. That's a bit of mystery for me. So he will always be a bit also that mystery. And by also not starting your point of reflection from the diagnosis or what you know, I think there we try to meet the other as another person. And of course, the contrast experiences already said, also in Stimul, are so heavy that you have to do something about it, as I also made clear, I think. You come out of stimul and you say, this has to be different. I have to do something. I feel, and I think that the deepest level of doing things different after immersion session is I have to ask people, I have to go into relation. That's the motivation that we need there. And I think it has also an impact on emotional level. And the impact of the stimulus sessions and of that kind of experiential learning is the impact on the emotion for me, and that's a very impressive emotion. You are so overwhelmed about what's happening that you feel shudder. You are hesitated. You did things like you did before, and now you cannot do that any longer like you did before. You feel, am I doing well? I don't know. How can I know what I have to do here? And that shudder, that hesitation is a first form, and I also learned that from Burggraven and Levinas, is maybe a first form of caring. The first form of caring is not doing something. It is not doing something. It is being interrupted. It is deroutinize, as I said earlier. It's stop doing what you think you have to do. It's thinking before you are doing and going to a relation before you are doing. And that kind of emotion is also a very important emotion. That's the shudder or the hesitation. And that's a first form of sensibility, of touchability. At that moment, you become touchable again, like the appeal of the tears of the patients in Yoko's story was the appeal for the nurse. Oh, I was in my routine. I have to listen to what's happening here. That makes her, that shudder, that hesitation of going through your program is the beginning of the ethics here and is a very important element of what's coming out also on the emotional level of the contrast experience in the stimuli. So I can conclude, I think, by giving space to experiences, not only contrast experiences, but we have seen that the amount of contrast experiences was so high in our immersion sessions. I think it's an important element. And we see that, I think, I look to you all, we see that also with our students, their experiences of witnessing things into the practice of every day are very often contrast experiences. I remember the words of a young physician who had his first internship in nursing home. No, it was on a geriatric ward. And he saw how doors were open. And he was so in shock. Is this, you can walk through the hall and you see naked people. This is not normal. Also in this kind of degree, it's not a high degree, but it is a contrast experience. And a lot of our students have a lot of these contrast experiences every day during their internship. So I think it is also important to see that kind of contrast experiences beneath other experiences of meaning, experiences of happiness, and so on, which are also important experiences. But I think contrast experiences are very highly valued in the learning process. I think we have, so by giving space to that kind of experiences, we try to cultivate character for care, even at the level of sensibility. And this space concerns being allowed and able to give words to these experiences and bringing them back to the source, being touched in our humanum, in what we share with all humans. That's what's happening with the contrast experience. And I think that's why we have to give words to it and to make space for reflect on it. This space is essential to remain sensitive and sensible. It feeds the moral character. And I already said, contrast experiences also overcome these professionals who are not open to ethical education, who are not, oh, I will give here relational care, who think I just try to do what I can do, but all these ethics, I don't mind. But if you see what another happens, like Joke's story, or you feel it yourself, you cannot do otherwise than doing something with it. So even when you're not open to relational care or ethics, this contrast experiences is breaking you open. And that's why I think it's so important to do something with it. By giving space to these experiences, we care about the ethical formation of even those healthcare professionals who do not seem to care about their own formation also. So that's one for the road. Experiential education in ethics is not only about tools or tools in teaching, even not only about experiential tools, what we do with this project. It's also about this, of course, but not only. It is in the first place about, I think, critical companionship to, for example, our nursing students or our staff members, our colleagues. And with critical companionship, I mean that we are their companions in their in their process of formation that is not stopping after their education and their formation here in school. It then only starts. And I think that it goes further with meeting critical companions, people who look with you critically to what is coming to you, in what you are experiencing in your everyday life of being a nurse at a ward. It's an invitation to make space in everyday situations to reflect on your own experiences. Also, the experiences of inconvenience, as my mentor Roger Burggraven say, that's the start of ethics, the malaise, the feeling of I'm not feeling well here. It's not good at all. So I want to end with Laura van Doren, who is a Dutch philosopher, stand-up philosopher. And in one of her very, very nice works, she wrote this: pain is a message from your body. It wants to tell you something. Something is wrong. Something needs to be done. Things are not going well. The same goes for being unhappy. It's a signal, a message. Unhappiness should be welcomed and given the best place at your table. You are sometimes unhappy for a reason. It's a signal that it is not enough, that you want to know more, say more, dare more, share more. It's a wake-up call, a signpost, a wound that under the plaster and the gentle healer is only getting worse. Meditating that feeling of unease away, eating away, exercising away, massaging away, and yogaing away is a great violation of our ability to grow. I thank you.